Okay, hopefully we're at the quiz 6/18/2026. Got a dozen cases. Here we go. Left upper quadrant pain. You can see a mass coming off the stomach. It's exophytic. There it is in the coronal view. I would have guessed that this was a GIST tumor, and I still would say this is a GIST tumor because of size and the potential. This was resected. It's both intraluminal and extraluminal, and this was a gastric schwannoma. Gastric schwannomas are benign tumors, they're rare. This should have been a GIST tumor, but was a schwannoma. Really nice case. Ectopic pancreas, evaluate this pancreatic mass. Cystic lesion, tail of pancreas, septations. You could think about a serous cystadenoma. I'm not thinking IPMN. Based on location, surely if the patient's female in their 40s, I would go with a mucinous cystic neoplasm or MCN. Cystic lesions, body, distally, and tail of pancreas. Septations, I gotta be thinking about an MCN. And with these septations, I gotta be thinking this is at least a moderate to a high-grade dysplasia, which indeed it was. Incidental adrenal lesion on the right, very vascular, right? No magic to it. Anything that vascular, yes, in theory, renal cell carcinoma metastatic to the adrenal could do it, but then you typically would see an absent kidney. I don't see anything with the kidney bad. This is 181. This is classic for pheochromocytoma. Okay, great case. Right upper quadrant pain, another adrenal mass. Homogeneous on non-contrast, some peripheral puddling and enhancement, arterial phase, peripheral vascularity on the arterial into the venous phase, and this was an adrenal cortical carcinoma. ACCs have variable appearances from solid to cystic, very vascular, relatively hypovascular, areas of fat, areas of calcification. Patient was doing yoga, big bleed in the region of the left adrenal gland. Again, bleeds can be PHEOs, that's number one, could be an ACC. Patients on Coumadin or some other anticoagulant, but a really large bleed. You couldn't exclude a tumor underlying it, and you're going to have to follow this patient up. But this was due to an adenoma. It eventually was resected, and it was a benign adenoma. Obviously, PHEO, you get lab values, but you still would have worried about an ACC. Patient was lucky. Right upper quadrant pain, another right adrenal lesion. Relatively low density, does not enhance to any significance like the other cases with contrast. It's low density on the late phase in the 20s. That was a lymphangioma. Two unusual lesions, ganglioneuromas and lymphangiomas, often wash out fairly quickly but don't enhance very much. And that's how you simply could think of them. They're benign lesions, but typically the way you make the diagnosis is by removing them. Abdominal pain and distension. You can see ascites. There's thickening of the peritoneal surface. This patient has carcinomatosis. And when you look at the cinematic rendering and you look at more of these images, diffuse thickening of the stomach, it's kind of like a linitis plastica appearance. There it is in the coronal view, and this was a primary gastric adenocarcinoma. Very nice case. Abdominal pain. A mass may be arising from the stomach. There it is, coming off the stomach, inferiorly large, homogeneous. Remember the first case we looked at, I thought about a GIST tumor, and it ended up being a schwannoma. I'm still going to go with a GIST tumor here. Homogeneous, lower density, coming off the stomach, exophytic. And this was a large gastric GIST tumor, which are typically resected. Patients will get Gleevec and will do well. Incidental finding off the stomach, densely calcified. Densely calcified, I always think about old hematomas. Leiomyomas can calcify. This would be a perfect GIST tumor. I've seen GIST tumors occasionally calcify, and the location being exophytic would be great. And this was a GIST tumor. I have to admit, except for this case, I've never seen a GIST tumor calcify like this. Patient with back pain. Look at the kidneys. not obstructed, low density. And then with contrast, you see several things. Renal masses in both kidneys, so bilateral renal tumors. You also will notice they're very vascular, so you're saying renal cell carcinoma. Could it just be one metastasized to the other, or they're synchronous primary tumors? This patient was young and also has an adrenal lesion, very vascular, could be a MET, right? And then you look some more and you say, wait a second, there's a lesion in the spinal cord. Now I have bilateral renal masses, I have adrenal masses, and I have a lesion in the cord. What can this be? Well, there is a syndrome we think about, von Hippel-Lindau, classic for the pancreas and renal lesions, also neuroendocrine tumors of the pancreas and pancreatic serous adenomas, but also spinal lesions. When you see spinal lesions in a renal mass, you got to be thinking about VHL. Okay, back pain. Patient, the pancreas is enlarged. There's edematous changes around the pancreas. Could be pancreatitis. There's no dilated duct. You could think about tumor. It's kind of low density, but there's no dilated duct. And you have this halo around the gland. And if you had to describe it, you'd say it's sausage-like. And if I say sausage, pancreas, halo around the gland, I got to be thinking of one thing, and that's autoimmune pancreatitis. And in fact, we did some AI work with radiomics with autoimmune pancreatitis. Well, those are the cases. I hope you enjoyed them. Sorry we're a few minutes late, but hey, better late than never. Anyway, with that, have a great day, everybody.